Welcome to the National Thrombosis Week virtual conference, and this session is on hospitals review and develop action plans to common contributing factors to potentially preventable hospital-acquired VTEs. And obviously this is arising from the NHS GIRFT report, Getting It Right First Time. I'm really delighted to welcome you all to this session, and I'm sure it's going to be really interesting and also enabling you to join in. Please use your question, your Q&A button in your toolbar to submit your questions, because this session is all about sharing, discussing. So while the panel in front will share examples that they have, they also welcome your questions. I'd also like to thank everybody involved in making National Thrombosis Week possible, from the outstanding medical leads who really give their time and collaboration, to professional bodies, including NNNN, the VT Exemplar Centres, UK Clinical Pharmacy Association, and others, and also organisations who support us through sponsorship in the exhibition area and in sponsored symposiums. Please do take time to visit the exhibition area. Alongside the companies, there are also the professional body stands, so you can have network, contacts, resources, and find out more. Okay, so waiting to begin, we have a panel of incredible VT champions who are able to share and discuss and answer your questions. And I feel very privileged today to introduce the chair, Dr. Lara Roberts, who is a consultant haematologist and the venous thromboembolism lead at King's College Hospital. She established the programme for root cause analysis of hospital-associated VT at King's and continues to oversee VT prevention practice across sites. She's a committee member of the British Society of Haematology Obstetric Haematology Special Interest Group and the specialty lead for the South London Clinical Research Network with Non-Malignant Haematology Group. She was also one of the key authors in the NHS GIRFT Report. So without further ado, let me pass over to Lara. Thank you.
Thank you, Jo. And thank you to everyone who's joined so far. As Jo said, this session is all about you and your questions. We're here to talk about the challenges in addressing common themes in potentially preventable hospital-associated thrombosis. So if you do have questions, please start entering those in the Q&A box. We have, as Jo said, a very expert panel joining me, and I'm very grateful to them. And I'll introduce who we've got now. So we have Rebecca Simpson. Becky is a lead nurse for VT prevention at Ashford and St Peter's Hospital, which she joined in 2013. Becky established the VT prevention service there and achieved VT Exemplar Centre status in 2016. She continues to oversee the VT prevention programme, which has been nationally commended, and she's currently working with a newly established multidisciplinary harm-free care team. Then we've got Bex Walsh, who's the lead pharmacist for anticoagulation and thrombosis prevention at Sheffield Teaching Hospital. Bex worked in oncology and palliative care before becoming the first pharmacist to be employed in the role of thrombosis prevention and anticoagulation at Sheffield in 2019. Bex is an active member of Yorkshire and Humber Anticoagulation Pharmacist Group and professional secretary of the local thrombosis committee. We've got Hugh Rowswell, who's a consultant nurse in thrombosis at University Hospitals Plymouth. He is also vice chair for the clinical leaders at thrombosis and a trustee for the British Society of Haematology. Hugh became a nurse consultant in 2016 with responsibility for investigating hospital-associated VTE, giving real-time feedback to clinicians, and was appointed as the hospital VT lead and chair of thrombosis committee in 2020. And in the room with me, I'm very lucky to be joined by Byrne, who's the principal pharmacist for anticoagulation at King's. She's deputy chair of the Haemostasis and Thrombosis subgroup at the UK Clinical Pharmacists Association. And one of her main roles is to promote the safe use of anticoagulation across the trust. And this includes safe management of both in and out patients receiving anticoagulation therapy. And finally, but most importantly, we have Emma G, who's a nurse consultant in thrombosis and coagulation. She joined King's 15 years ago as a coagulation clinical nurse specialist and became a nurse consultant in 2014 with responsibility for the nursing thrombosis teams across all King's sites. And shortly after this, she became lead of the VT National Nursing and Midwifery Network. So thank you for all of you taking the time to join the panel today. I can see we've now got 70 participants who have joined, but no questions and answers yet. So please do start entering those. I'm just going to start, while you're thinking about those, with just some summary slides from the GIRFT Thrombosis Report. I'm just going to share my screen. So this thrombosis survey was undertaken in conjunction with the Getting It Right First Time team, who are based at the Royal National Orthopaedic Hospital. And the GIRFT programme is aimed at identifying and reducing unwanted variation in clinical practice. And in conjunction with Thrombosis UK, we were very lucky to have their support in performing this national survey. So at that time, there were 144 NHS trusts invited, and 103 participated, and there were 96 unique trusts with 7 reporting data by site. And you can see it covered most of England fairly well. We're talking today just about the hospital-associated VTE survey, which was survey 3. And there are 84 participants to this survey, and they contributed just over 4,500 episodes of hospital-associated thrombosis. And the number reported per site varied widely. The mean was just over 50, but it ranged from 1 to almost 300. And we'll have to remember that this survey started in October 2019 and was due to close in March 2020. So of course there was a lot of disruption with data entry with the advent of COVID. And I think that probably limited data entry for some sites. But with the data available, we were able to work out a median rate using hospital episode statistics to work out how many admissions there'd been, and that was 1.7. And if we excluded sites reporting a low number of cases, it only left 36 sites, but the rate for those sites was then 2.3 per 1,000 admissions. And if we look at rate by type of admission, each bar represents a single site. So you can see there's huge variation, and this is probably in part due to numbers reported. But the greatest group at risk is actually medical patients. And you can see the event numbers in obstetrics is much lower, which is probably not surprising. If we look at underlying themes for why people were developing hospital-associated thrombosis, the most common theme is actually thromboprophylaxis failure. So these are patients who were risk assessed, received appropriate thromboprophylaxis, but still went on to develop a thrombosis either during the admission or the 90 days following admission. The group we're most interested in is the one in red, and this still comprised 13% of all submissions where there was inadequate thromboprophylaxis given. And when we look at possible themes, on this graph, the red bar is of all hospital-associated thrombosis, and the blue is where we consider them to be potentially preventable. So not having a risk assessment or being incorrectly risk assessed was sort of associated with potentially preventable events. You can see that reassessment was very poorly done. So even overall, more than half of the patients didn't have a reassessment. Not having mechanical prophylaxis prescribed or anticoagulant prophylaxis prescribed, or a delay in prescription was common. Missed doses of anticoagulant prophylaxis was common. And whilst NICE doesn't recommend dosing thromboprophylaxis based on weight, from the participants of the survey, over 60% of centres do use weight-based dosing, and this was again a common theme in potentially preventable events. And then there were smaller numbers who didn't get post-discharge prophylaxis prescribed. So what we really want to talk about now is how we address those themes. And I can see there's still no questions from the audience, so you're going to have to go with my questions. So I might start with Bex and Ros with the wrong dose for weight, because this has been an issue that we've had locally. Wanted to comment first, Bex, on whether that's an issue at Sheffield and how.
Yeah, a pulse from my noisy colleague. Ros, will you go first? Because then I'll shut this lot up while you answer.
Yes, will do. Yeah, so we had quite a high proportion of potentially preventable HATs that were associated with wrong dose for weight. So we tried to look for an electronic solution to this, but unfortunately that wasn't possible with our current prescribing system and may be possible with our new one, but we're investigating that at the moment. So ideally you'd have a solution where it calculated or prompted at least the correct dose for weight. The electronic prescribing system did that. Unfortunately, we can't do that. So we sort of approached it initially from a teaching point of view. Obviously, pharmacists are ideally placed to make an intervention around the dosage, especially in relation to the weight. So we did some teaching with the pharmacists around that and around right weight for creatinine clearance as well. And then because we found the problem often was that the weight wasn't recorded initially when the dose was prescribed, so that quite often the dose was prescribed on an estimated weight, and then the weight would be recorded later, but the dose not adjusted. So we would just had agreement in our medicines policy for the pharmacist to endorse that the dose is based on an estimated weight and to adjust the dose as appropriate when the weight was recorded accurately. So we're yet to audit whether that has made a difference, but it's quite difficult without an electronic solution. I think ideally we'd have an electronic solution to the
Our themes are similar, actually, Ros. And culturally, across our organisation, the documentation of patients' weight is poor to start with. We have noticed there's a lot of tolerance for patients self-reporting weight, and invariably they report in stones. And so somebody does a Google conversion from stones to kilograms. That's not to say that that is even an accurate weight to start with. So the potential for inaccuracies just sort of grows and grows. Following quite a significant incident with heparin, we are now a bit keener on actually putting people onto scales and documenting that where possible. So that was even just wider than a medicine issue. That was a patient welfare issue, really. I think there's good understanding of a weight-based dose approach to using low molecular weight heparin. The places where apart from them, I mean, there have been some obvious clangers where people who are really significantly over 100 kilograms have got 5,000. But where we sort of wobble about a little bit is patients where if they're admitted straight to critical care, they get an adjusted weight on the critical care prescription system. And we use actual body weight to dose low molecular weight heparin. So sometimes there's a little bit of confusion there, or if they're estimated at around 100 kilograms, then sort of trying to guide an appropriate decision as to whether to go for a slightly increased dose. So our dose bands and our dose recommendations are under review. But certainly after 100 kilograms, we'd recommend 7,500 of dolteparin once a day, and after 150 kilograms, we are currently recommending 5,000 BD, which I think is a little bit lower than other organisations. So we are in the process of reviewing that.
Thank you. And so we have now got a question in the Q&A box, so thank you. And that's asking to share how we're tackling missed doses of thromboprophylaxis and delayed prescribing. So perhaps we'll do those separately. Becky, do you want to talk about your approach to missed doses? Well, actually, you've got your hand up. Were you going to comment on the weight as well?
Yeah, sorry, I just I had just going back to the weight. We've noticed really similar themes to what you guys have prescribed, actually, and it's kind of moved on from there ever so slightly. So we had the issue with the estimated weights and the weights not being recorded appropriately, and then as we all of our cases from last year that were potentially preventable were due to suboptimal dosing around the weight-based dosing protocol that we have. And when we looked into them, they were all because of inaccurate weights recorded initially, and then the doses not being adjusted. What we found in this current year that we're just closing up is that we've had a high proportion of patients who have capacity who have refused to have their weight recorded. And that's then added in an extra element where some of the clinicians have been quite uncomfortable with how to dose, and we've had to provide lots of advice and reassurance there. And it's quite a tricky one because the patients have been very open and wanted to have prophylaxis, but for whatever reason have not wanted to be weighed. So that was a new challenge for us. That was something we hadn't had before, and they were patients that had come across from the mental health setting. So that was quite a challenge for us with the weight-based dosing protocol. And one of the other themes that has come up for us recently are the patients in the underweight cohort that we're finding are actually having a dose that's too high for their weight. Thankfully, we haven't recorded any adverse outcomes for those patients with regards to bleeding events, but that's kind of something that we've picked up in our themes there with regards to the weight-based dosing. Going to, was it omissions, the next part of the question? So going back to that, kind of when we first started the programme around in 2013, our biggest issue initially was that the patients weren't being necessarily risk assessed and therefore weren't having the prescribing. When we moved on for that, our biggest issue was omissions. And I shared on Wednesday, we had two really, really big drivers. And one of them was all of our potentially preventable HATs were due to omissions of chemical prophylaxis. And we had a really unfortunate death due to a potentially preventable pulmonary embolism, and within that case there were multiple omitted doses of chemical prophylaxis. And we kind of all got around the table and put our heads together and thought, what can we do, what can be our approach to this to ensure that this doesn't happen to anybody else in our care? And we're really, really lucky at Ashford and St Peters because we've got a fabulous QI and programme management team. And we came together and we started off a medication safety programme, which initially was looking at the VTE omissions. And then we spread out to look at all omissions of all. We started with critical drugs and then moved out to all omissions. But with particular focus on the VTE omissions, we started small. We had 4 pilot wards and we tried lots of different interventions. We had to try and assess what the problem was and understand what the problem was. Why were these omissions happening? And there were lots of different issues. Mainly, the people who were administering the drugs were getting interrupted during the drug round. So we tried an intervention to stop that. We got these fabulous bright red tabards that said, you know, don't interrupt, we're doing the drug round. They didn't work because everyone kept coming up to them and saying, oh, yeah, I know I'm not supposed to interrupt you, but so that one didn't work. We found some problems with how the drugs were stored and they were coming up from pharmacy and not necessarily being unpacked. So the omission code was getting put in the drug chart to say the drug wasn't available because people weren't looking because it wasn't where it was supposed to be. So they were saying it wasn't there and then not going on and doing anything about that because they were going on about their busy shift. Sometimes there is an issue where you've got a really cohesive team and they might have had, one of the nurses had put in a omission code for nurse's decision to omit, hadn't necessarily documented why that decision was made, but then the next nurse that came on shift thought, you know, I've worked with Irene for 20 years, she's brilliant, she wouldn't omit a drug for no reason, so I'll omit it until I find out why she's omitted it. And then that just continued. So we had all of these kind of little practice issues, and the only thing that we did that actually worked and drove down the emissions to the point where none of our potentially preventable HATs last year or so far this year are due to omitted doses was doing a drug chart check at bedside handover. It sounds really simple. It wasn't simple to implement at all because we had all the usual challenges of, oh, we can't do that, it's too busy, we haven't got enough time to discuss that at every bedside handover, but it really worked. They'd go through, we'd do the handover, we'd look at the drug chart and look at all, why was this omitted, and then we'd action it and deal with it at the time so it didn't get missed and the omissions didn't then continue. Sounds simple, but like I say, it wasn't. It was actually really, really quite hard work to get that embedded, but now it's embedded in practice. It's kind of like everyone's standard practice and everyone does that. Having said that, we're moving to electronic prescribing next week. So I'm not quite sure how that's going to affect that process we've established with the paper-based drug charts, but that's kind of what we did, and that's what worked for us, but it was a lot of trial and error.
Thanks, Becky. That sounds like a lot of effort and work, but I'm pleased it worked for you in the end.
Yeah, it's good.
Does someone who has electronic prescribing want to comment? I don't know, Emma, do you want to comment, or Hugh?
Yeah, we have electronic prescribing for the last 18 months, and historically the problem always was you're doing an RCA, you get the drug chart. If you could find it, then there'd be a gap, a blank square or a tick, and it wasn't really clear if it was given. The big advantage straight away is that you generally know whether it's been given or not. We have the same problem the number of times as the patients refuse to take it, or it's been paused because they're waiting for a scan, and that the scan took place 2 days ago, and people are just, once again, you still have the same problem. They'll continually omitting it because somebody else did. It's much better because at least now you have to say something there, whereas historically, say, you don't get the gaps anymore. So it's certainly better, but it's not the total solution. You still have to work at it, but it certainly has improved matters having electronic prescribing, definitely.
No, I mean, just to add here that obviously one of the benefits is much easier audit, isn't it? It's far easier for us centrally to audit. And also we've been able to implement a missed doses column on our ward view. So on the electronic drug prescribing chart, we've got a summary view whereby clinicians on the wards can see their whole wards and particular tasks that remain outstanding. One of those columns is low rate heparin emissions, so they can quickly look and see what's going on here with this patient and investigate it. One of the themes that we had was patient refusal here. And as Becky alluded to, the talk from Wednesday is well worth a listen back. Some really nice ideas about how to plan a quality improvement project around low rate heparin emissions from both Becky's site and from King's as well.
Thank you. So the other part of that question was about delayed prescribing. And I think this is possibly a theme we'll see more of with the new NICE quality standard, being that we should be administering thromboprophylaxis within 14 hours of admission. And I guess there might be some issues in how you define admission, and particularly now where in some places patients are in ED for a long time before moving to a ward area. But let's just stick with 14 hours from admission. Ros, do you have any suggestions for how we can make sure that there isn't a delay?
I think, well, from a pharmacist's point of view, it's not always easy because we don't necessarily see the patients that quickly. But I guess we've tried to embed beta risk assessment in our medicines rec process. So I guess it becomes part of when the pharmacist or the pharmacy tech first sees the patient and they do the drug history and reconcile all the medicines, that they check that the BT risk assessment has been done and the prescribing has been done appropriately, and I guess that the dose has been given. But it's quite difficult to do that within 14 hours for all patients, I would say, from a pharmacy point of view. I don't know if anyone else has got any better ideas, but
it is going to be challenging because, like we've already talked about, it relies on having an accurate weight. If the person is admitted in the night, particularly if it's after 6 p.m, the traditional time to give low rate heparin in most hospitals, then getting that patient weighed in the night, and I think it's about changing the culture as well and letting people know, yes, it is okay to give that dose of low rate heparin later on in the evening. And on Wednesday, Ria from Ashford and St. Peter's talked about the power of data. And I think that once we start to get the data through and we can see how many patients are getting their low rate heparin within 14 hours and how many aren't, I think naturally that will improve awareness, and we'll be able to sort of go with that and give people a little bit of reassurance and education that, yes, you must still give it and not wait till 6 p.m. the following evening. I wonder actually if anybody gives the low rate heparin at a different time, or how it works. Does it get prescribed PRN or a once only drug? I suppose it would be, wouldn't it, if a patient got admitted out of hours?
I think on our charts there's an option for a stat, isn't there?
Yeah,
and
there
then so that you have to actually tick that. Becky, you've got your hand up, or is that an old hand?
No, it's a new hand. Yeah, the 14 hours is a real challenge. We've been auditing it for nearly 2 years now, and we do a retrospective cohort audit, so for the previous month. And when we first did it to establish baseline, we found that 65% of patients were receiving their first dose of chemical prophylaxis within 14 hours of admission. And we kind of thought, oh, do you know what? We actually don't know what to do about this and how to increase it, because we had all the information. We've got all the information visible on the wards about prescribing stat doses, because same as you guys, our kind of standard dosing time is 1800, as it is at most sites. So we did a huge drive around the wards, lots of we call it tea trolley training. So we go around with a tea trolley and give people drinks and pens and do kind of on the spot training. What was really, really interesting when we started measuring it was, obviously this happened at the advent of the pandemic as well, when we started measuring this data. And as we started changing the protocols for prophylaxis in patients who were COVID positive and all of that kind of stuff, there was so much information going out, and we were really concerned about how confusing that was going to be for people. So we were quite visible. We were going around on the wards doing all of this training, but people got so aware, I think, of the prescribing of prophylaxis with the association with COVID, that actually during that time we saw a massive increase to kind of 87% of patients receiving their first dose. And the only thing we could attribute it to, because all we were doing was going around the wards doing these little tea trolley sessions. And that didn't make any difference at the beginning. And then all of a sudden, during COVID, it just shot up and it stayed up there. So again, going back to Emma's point, I think a lot of it is to do with awareness, and the awareness of the effect of how important that first dose is within that time frame.
Thank you. So we've got another question now. Yeah, more about identification of HATs and reliance on radiology reports. And the person asking the question says they have no VTE nurses and are reliant on reporters, but finding under reporting, radiology are unable to send positive VTE and link to hospital admission, readmission within 90 days. Any advice? So I think from the GIRFT survey, it was quite clear that radiology reports are the best way to find these reliably, and using other methods, there was a clear association with less reports, although obviously there's potential other reasons for that with COVID. And it is laborious, unfortunately. It is time consuming, and at King's, radiology are only able to send us a list of everyone who's had a scan, so we still have to manually go through to find the positives and then go through the positives to see if they're associated with a hospital admission. I don't know what others are doing. Bex, you've got your hand up.
Thanks. We rely almost exclusively on radiology, which obviously excludes bedside diagnoses or clinical suspicion, but is the mainstay of our information source for patients with hospital clots. Radiology department are helpfully able to put in some sort of electronic tag into their reports, which identifies positive, negative, or equivocal. So that can filter out some from there. And then the information, the patients with positive scans, their details get sent to our information services department, who then match that data with hospital admissions. So that's enormously helpful for us, because it sounds as if you guys are trawling, and that is labour intensive. So then we are able to do some more filtering of the data, and so the data we get sometimes needs further investigation. So depending on what is classed as a hospital admission, it could be a visit to triage at our maternity wing, and we can exclude from there, but that is hugely helpful. Yeah, so I'm happy to be contacted direct if who's asked the question, don't know, anonymous. If you want more info on that, yeah, drop me a line and I can set you up with the people who've made that happen here. We also get info from our coroner, and we started doing that a little while ago. They gave us a bit of a funny look when we first asked for that data in the coroner's office, but now I think they're sympathetic and supportive of what we're trying to achieve. So we get, and it's not particularly significant in terms of number, but I think it sends the right message to the coroner's office that we're taking this really seriously and we really want to know about people who die of VTE, which is hospital acquired or hospital associated.
Yeah, we have a similar arrangement with our bereavement office, but there's just a bit of delay in getting that data. But I agree it's important that we look at those, because that's what we're really aiming to prevent, isn't it? Any potentially preventable deaths. But that's really useful. I think we might be contacting you to see if our radiology can set up those tags. I'm not sure. We unfortunately have a lot of our reporting outsourced to Medicus. I'm not sure how well that will work, but it would be helpful if we could.
It's not without error. So if nobody puts a tag in, then it gets lost in the pile of miscellaneous, which we don't go through. So, you know, there's gaps all over the place. But I think in terms of where to start, it's a good place to start.
Yeah. So there's another question here, again, anonymous questioner, but do we think the lack of visiting during COVID helped with timely administration of subcut injections? I don't know, Becky, did you find your interruptions were from visitors or were they staff interruptions?
Staff. Yeah, definitely staff interruptions. But having said that, I mean, that's a difficult one, because although we had the interruption to the visiting, actually the staff were much more intensive in terms of the time that they were spending with the patients due to the lack of visitation. So they were spending time with the patients, with the iPads, kind of facilitating the communication with the family. So I don't think it actually opened up any more time or released any more time to do any more care activities, although we didn't measure it. That's just my kind of reflection on what I saw.
Thank you. Your hands up. Is that for the radiology report?
Yeah, I was saying, interesting, a couple of the medical wards actually switched from 6 to 10 p.m. The argument being the 6 p.m. was a really bad time. Patients are eating food. There's always business there. You couldn't get to the patient. And actually, it was much better. Tended to work much better for them because everyone was in bed then, much easier to get to the patient. And it's really successful. In surgery, they have more worries about, haven't done it so much. But medicine, certainly, we found that's been a huge improvement, giving it a bit later.
So I guess that maybe COVID did help for those 6 o'clock administrations, but we just don't have any data from anyone here about that. There's another question here. Would be helpful if any trusts had action plans in response to the GIRFT findings and recommendations that can be shared. This was also asked at a session, I think on Tuesday this week. So I know that early on we had very few responses to the site packs. I think there were less than 5, but I have emailed Anne-Marie on Tuesday to ask whether she's had any more returned, and we'll try and collate those and perhaps share them through the Thrombosis UK website. Unfortunately, she's on leave until late next week, so it's probably not going to be an immediate action, but we will take that back. If you I guess either keep an eye on the Thrombosis UK website, or if you'd like a personal response, then perhaps email me and I'll try and forward it on. So there's another question. Is there a presentation on GIRFT findings we can share with organisations? So we have, last year we did a couple of presentations, one for National Thrombosis Week and another one for National Thrombosis Day, I think, in October. So I think they are probably recorded, Joe. I don't know, are they available still for people to access, or would they have been archived?
Yeah, I'm in fact just searching to get the link. They are on the Thrombosis UK website. There's a page that's called GIRFT. And so I'll send the link there. And actually, I'll put it on the e-shot that we send out each day after the sessions, because both the report and the films that were made are on that site. So people can easily access it. Yeah. Equally, if we do get any action plans, I'll make sure that we share them so people can know where they are and can go and have a look.
Thank you. Great. So I think that's all the live questions at the moment. So I've got a couple of other questions that I was going to ask. One of the themes that we're still seeing relates to the reassessment of VT risk. So we often have patients who come in and are thought to be at high bleeding risk, either because they're actually bleeding or they're suspected to have an intracranial bleed and still awaiting for imaging, so there's no thromboprophylaxis prescribed. But then they later have the imaging or they stop bleeding a few days later, but no one comes to think about restarting thromboprophylaxis. So Bex, you've got your hand up. I'm not sure if you put that up before I was started asking about that or whether you want to talk about that.
So there's a question in the chat that I wanted to bring to your attention. So that's all. That's why my hand is up. We'll come back to it.
On the reassessment, or otherwise, I know Hugh did a QI project around this previously, and maybe you could talk to us how, I think it was in neurosurgery, wasn't it? But how you actually got the neurosurgeons on board and.
Yeah, exactly. Yeah, obviously when we started collecting data on HATs, we really wanted to know where the problems were. And as you said before, medicine has had the biggest number, but then they saw the most patients. So as a percentage of their admissions, it wasn't that big a problem. Whereas neurosurgery, and Plymouth is a regional centre, so you have a lot of neurosurgery patients. It was over 1% of their patients getting hospital-acquired thrombosis. So this seems incredibly high. So we had a look at it, and again, the problem was they often would come in with this quite big bleed risk, but actually they were never getting reassessed. So the first thing, we were really lucky. We had a really good link nurse that worked there, and I was lucky enough to present to the neurosurgery team just to find out where they were in their data, how many HATs they were seeing. Because it's always the problem we've always had is that a lot of the time the HATs were happening after they'd left the hospital, so they weren't necessarily aware of the extent of the problem. So we kind of first of all raised them, this is where we are, stressing the importance of reassessment and actually on their kind of ward rounds, making sure, can we restart it? And it was just, and also that kind of presenting the data, and we went from 1% down to 0.5%. We kind of halved the rate of VTE in neurosurgery. And I think it was a lot of combination of giving them the data, having a link nurse to kind of bring this home, and even going forward, it seems to have stayed. We're much better now at reassessing and starting fairly quickly chemical prophylaxis once bleed risk disappears. So it was a lot of work, but actually, fortunately, even all these years later, it still seems to be there, that we are still not seeing the issues people historically seeing in neurosurgery.
Thank you. I think that's something that we're trying to do here as well. So just as part of the board round, they're going through the whole wards list and particularly focusing on those who have a high bleeding risk to see whether they can be reassessed and started. We're just in the process of auditing whether that's had an impact. Did anyone else want to comment on the reassessment? And then we'll move to some of the questions in the chat that I'd missed.
I think with the reassessment, I think the main challenge is that unlike some of the other interventions, we can't make it routine. I know initially in the NICE guidance, it talked about reassessing after 24 hours. And we found that sometimes actually that wasn't quite right. It was too soon and people were actually resenting having to do that. And that sometimes it isn't until a bit later, maybe 48 hours or even later in their hospital stay. And like I say, we know that it's quite difficult. We can't create an electronic alert. That's our go-to in the CMC these days. Can we have an electronic alert? You can't, because you can't know when that patient's clinical condition has changed. Like Lara said, I think embedding it into everyday practice, so board rounds, getting nurses to think about it, handover, making it multidisciplinary issue, I think is the way forwards. I think hopefully both Ros and Bex would agree that pharmacists are very good at this whenever they're they're on the wards each day, noticing when patient's condition changes, or they've had a CT scan perhaps to rule out a stroke or a bleed, and maybe in a good place then to prompt prescribing, or at least thought about reassessment. But I think that's why it's been so challenging, because we can't make it routine. We have to rely on clinical decision making and judgment. And that's why I think ward rounds are a really good place for that sort of reassessment to happen.
Thank you, Emma. Bex, did you want to go on to the question you were keen to tackle in the chat?
Yeah, just I don't know if everyone can see the chat. I think they can. So there's a question about a HAT related to an ectopic pregnancy, and difficulty implementing VTE risk assessment in OBS and gynae in particular for this in this organisation. So I don't fully understand the admission pathways for our patients in very early pregnancy, but I think it must be different to later on in pregnancy, because that would explain why we have a risk assessment tool specifically for less than 18 weeks, women who are less than 18 weeks pregnant. Now, it doesn't really matter, does it? It's a bit of paper. You can use a bit of paper anywhere in the organisation, but that certainly seems to help identify women who might otherwise, I think, not have been considered for A, risk assessment, and B, appropriate prophylaxis. So I don't know the thinking behind that, but that seems to have met the need in that area. I can find out more if it's helpful. Again, contact me direct, and I can speak to the senior nurses in that area. I think there was an interest there. I think they've had liaison with the haematologists. They know to flag up high-risk women even before our COG guidance was updated. So I think they were on it anyway, and that helps. But certainly that tool is helpful because it's able to specify action to be taken for women who have pregnancy loss, so miscarriage, ectopic termination, who may need thromboprophylaxis post that event.
Thanks, Bex. Would you mind sharing your email in the chat just so people know how to contact you if they do want to reach out? Sure. I'm not sure if it's on the programme. I think we've also had issues in getting gynecology to engage with the risk assessment process here. And for years, we tried lots of education things, and the problem with staff turnover was you'd make a difference, and then the doctors would all rotate, and we'd be back to square one again. So in the end, at the request of their governance, they actually now have a hard stop on prescribing, and until they've done a VT risk assessment, they can't actually prescribe anything else on the electronic prescription chart, and that has dramatically improved risk assessment rates. And we didn't have a lot of HATs from that area, but there's certainly less now than there were previously. So I don't know if that helps. We still use the standard national risk assessment tool for women in early pregnancy who are admitted under gynecology, although they are all aware of the RCOG call. But generally, any woman who is pregnant would get thromboprophylaxis, unless there are high bleeding risk here, which I guess would be if they're about to go to surgery for the ectopic, it wouldn't start till afterwards. Does anyone else have any comments on that question? There's a couple of other questions in the Q&A now. So is there somewhere we can see Trust QI projects and topics to help locally with ideas and implementation? I know on the NICE page, they have some reports, don't they, where people have successfully implemented and demonstrated improvements. Do we have anything on the national website?
Yeah, on the vtengland.org.uk under the resources tab, there are some poster presentations from various QI projects, and I think we're doing a refresh of the website at the moment. So over the next couple of months, we'll be populating that with more of this kind of thing, because I think we're getting the message that that's what people really want. It's access to resources and sharing that information.
Thank you. And there's another question here. Who is responsible for leading and monitoring VTE risk assessment, performance and reporting to execs? Is it led by haematology or hospital director, etc.? So I suspect that probably varies by site. Does everyone want to comment on how it's done? Becky, do you want to tell us how you do it at St. Peter's and Ashford?
So I'm responsible for all of the reporting, and I lead on all of the reporting, and we feed into various committees and various groups. Obviously we have the local thrombosis committee that feeds into the quality and safety committee. I report directly to the quality and safety committee, which is made up of patient panel members, the CCG, hospital patient focus groups. I also report directly into the quality report committee. They all sound very similar, and that's the committee with the execs and the NEDs on. So I report into them bi-monthly, and they're very quizzical on any change, whether positive or negative. But it's good because it means we get the support if we do need to put anything in place or make any changes. I'm responsible. So the VTE team are responsible for all of the data collation and reporting to all the various different places.
Thanks, Becky. Hugh, what do you do at Plymouth?
Well, in Plymouth, I have the joy of being the trust lead and chair of the thrombosis committee, so I guess it comes down to me. Of course, interestingly, one of the things that was always around was the risk assessment, the 95%, which took some time to get on board, but we now sorted that, even though we're not actually having to collect it anymore, but actually we have worked it out. But the idea is that we try and produce every year, we look at VTE by any speciality compared with the admissions and look at, is it getting worse? Any areas where it particularly seems to be getting worse? Anything we need to do? Lots of work around the missed doses, the inappropriate prescribing, and you kind of give real-time feedback, which is always one of the big things we really push. That if a surgeon discharges a patient, unless we tell them, they won't know it's happened. So, and it certainly has had an impact. But yeah, but it is something that I have the joy of leading on.
Thank you. What happens in Sheffield, Bex?
We're quite a devolved organisation, so I sort of feel as if we're quite hands-off in terms of that whole process. The data collection is done by the coders. It's reported to the thrombosis committee and via the thrombosis committee, but it's up to the directorates to own that and improve that data, which can be helpful and unhelpful at the same time, because it means that affecting a cross-organisation change is a big fat no usually, because of this devolved approach to directorates. And I understand that because each directorate is different, patient populations are different. This can be frustrating when there's no central sort of ownership or leadership, or it's harder to affect a change and there is central acknowledgement of, yeah, we've got a bit of a problem here. How do we fix it? Oh, well, you need to work with the directorates to fix it. It can be a really challenging approach. The whole sort of data collection, we have carried on collecting data actually. Our poor coders were deceived into collecting data for VT risk assessment, even while the scheme was paused. And actually they found that it's getting harder to get to 95%, which is interesting. I know there's been talk of a slightly different approach from to data collection, which would, I think, help. The clinicians in the early days lost confidence in the data that was being collected by the coders and the central team. So I think they're minded to dismiss it, which is a shame. So we're collecting data on a monthly basis. It's really hard work, that the clinicians say, well, I know our risk assessment rate's better than that, and I'm not frightened of this data that tells me it isn't. Yeah, so lots of lots of people doing lots of hard work, and lots more work to be done, I think.
Emma, do you want to comment?
Yeah, so obviously we have an electronic system. So before we had the electronic system, though, it was a lot more challenging. And I'm aware that a lot of trusts are on paper. So I'll just mention briefly what we did then. We used to have paper risk assessments. At one of our sites, it was within the medication chart, which I think worked quite nicely actually. And there's quite a nice prompt then for the thromboprophylaxis to be prescribed. And at one of the sites, the coders, like in Sheffield, Bex, the coders would manually count the number of risk assessments that were undertaken. But obviously that was quite retrospective because we had to wait until discharge. So there are lots of flaws in that, but it was all we had at the time. On the main site, the risk assessments were done on paper, but then we did use and adapt one of our electronic systems to have a tick box. So even though they wouldn't do the risk assessment electronically, they would tick that box to say, yes, it was done. Again, not a perfect system by any means. Now our electronic risk assessments are electronic, so obviously, so data collection is much easier. Our business intelligence unit help collate that data and send it to our thrombosis committee for us to check that that data sort of makes sense and just to sense check it. And then it's down to us to disseminate that and work with the departments to improve where needed.
Thank you. I guess as part of that, we do disseminate monthly reports through to all the governance leads, and that has sort of helped. It does come up on their quality scorecards, doesn't it? So we have had more engagement, and a lot of them coming back to us saying, well, we need something more, and that's led to some areas having these hard stops for VT risk assessment just because they weren't able to improve that otherwise. But I think that's been very effective because our risk assessment rates, I think, are still about 98% through those processes.
There are some centres, aren't there, that have mandatory hard stop throughout. So on an electronic system, they can't proceed at all to prescribing until the risk assessment's done, and that happens throughout the hospital, which is an easy win. And I think that we were concerned about emergency prescription of medications, and I think the way that some centres have overcome that is that they have stat dose prescribing unlocked, so that if in an emergency any medication is needed to be prescribed, that can still happen, but for your regular routine prescribing, they can't proceed until the risk assessment has been performed. Unfortunately, the current system that we've got doesn't allow for that stat prescribing, which is why, as Lara said, it had to be a voluntary system. But hopefully moving forward, once we get our new system, that might be something that we can revisit with them.
Thank you. So I'm aware of time. There's a couple of questions I might not get to, but we can try and feed back later. Someone's commented that one of their challenges is maintaining engagement with the executives to keep VTE as a safety priority. I don't know if anyone on the panel has encountered that.
So yeah, when obviously it wasn't a national secret anymore, we obviously lost quite a powerful driver with the execs at that point. So we decided to keep all of the indicators and put them into our internal quality KPIs, and obviously they've evolved over the years, and now we're moving towards kind of harm-free care practice we do at our trust. So I'm not sure about the terminology yet, we haven't quite got there, but we have kind of these areas of harm, one of them being VTE. So within that package we have our internal quality KPIs that go into the quality report. So for us, we have the risk assessment rate. We have a target to achieve 80% of patients receiving their first dose within 14 hours. We have a target that all of the potentially preventable HATs will be less than 5% of the total number of HATs. And each year, depending on what's happening and the challenges and the themes of what we're seeing, we change those internal quality indicators. And that works really well for us. It's really powerful. It keeps everyone engaged. It's not necessarily going to work for everybody, but that's how we did it when we lost the sequin.
Thank you. There's another question here that, again, we might do a quick round about who chairs the thrombosis committee. I think, again, that's going to vary by site quite a lot. I think you've already said you chair it at Plymouth. Who chairs it at Ashford and St Peter's?
So one of the consultant haematologists chairs it. It kind of rotates. So it's like it will either be me or one of the consultant haematologists.
And Bex, what happens in Sheffield?
So the lead consultant haematologist for thrombosis prevention chairs it, and the lead for anti-coag safety is in attendance. So she's deputy chair, I think. So yeah, good consultant buy-in. I know some areas and some trusts really struggle to get haematologists time for this. So if you're one of those places, don't despair, because you're not alone. It's really incredible. I find it really difficult to imagine a haematologist that's not interested, or that's not fair, that doesn't have the time in their job plan to commit to thrombosis committee, but that's the reality for some of them. And so it might be chaired by a surgeon with a special interest in VTE, yeah, a patient safety manager. There's all sorts, because thrombosis prevention spans all sorts of areas, doesn't it? So I think whatever model we've got might not reflect what would be appropriate somewhere else.
I think that's true. I think even across the exemplar network, there's a lot of variation. Norfolk has a consultant geriatrician, I think, don't they? So I think, like you say, it just needs to be someone who's interested, and will help champion VTE prevention, regardless of their specialty or profession. I don't think it has to be a medical professional. It's Hugh in Plymouth, and I think it could easily be a pharmacist in some centres if they were interested. So I'm aware of time. I think that Bex has very kindly answered one of the other questions in the chat, and I think Sheffield's not alone there. I think at GSTT it's a pharmacist who leads the HAT root cause analysis as well. So I'd just like to thank all of our panelists. It's been really useful discussion. I hope all of the participants have got something for this. The session has been recorded, so you can go back to it later or share it with colleagues. And I would encourage you all to visit the exhibition area, where there are more resources that you can access from both the National Nursing and Midwifery Network and also the VTE Exemplar Centre website.